you very much. Thank you for having us. We're really excited to be here. I am Emma, and we're going to talk to you today, as already illustrated, about the importance of combining clinical and design expertise. And to do that, we came up with this really silly talk title.
Hi everyone, I'm Videha, and this is going to be really fun because we're going to tell you about a real-world, pretty messy case study of designing services in the NHS. We'll start by telling you a bit about ourselves and why we started to work together, and then we'll tell you about a project that Emma and I worked on and share some key reasons why we believe bringing design and clinical expertise together is really important. Hopefully this will be relevant to you if any of you work in healthcare or other public sectors, public services, or even if you're more broadly trying to innovate in complex and constrained environments, which I think most of us are these days. We've already had some great talks today, and we hope that we will be able to leave you with a little bit of inspiration and maybe a little bit of hope for the future, reflecting back what we heard at the start of the day. But we wanted to keep this pretty light. We have purposely left some time at the end for questions and feedback, so we're very, very keen for you to think of anything that we talk about that you maybe don't agree with, or maybe you've got a different perspective, or anything you want us to expand on, then please do share at the end. We'll purposely leave some time for that.
So, unless you haven't guessed yet, I am the designer in this partnership. I've been a designer for nearly 20 years now, which feels scary to say. I am definitely in the middle, and I just cried in the middle of that last talk. So thanks for that. I have been a service designer for 12 of those years, and for the last 4 years, I have been freelance, as also illustrated in the last talk, quite a common move to make. I started working for myself and I started my own company, as included in the intro, called Design for Joy. Actually because at the time I wasn't feeling a lot of joy. So if anyone wants to hear that story, that's one for the pub. I work mainly with public and charity sector clients to design services that work for people. And I've worked with charities like Rape Crisis and the Royal Osteoporosis Society, and I do a lot of work in healthcare. I'm currently working at NHS England on some prevention services, so one of those 3 big shifts, actually 2 of the 3 big shifts I'm working on, so I'll probably be employed for the next 10 years, which is great, so thanks Rochelle for highlighting that. So because I am a service designer, and I'm sure there might be a few dotted around the room, people think I spend a lot of time doing this, moving post-it notes around walls, or in this case, normally digital whiteboards, more often than not, sadly, these days. What I actually love the most about my job is spending time in places like this, observing how the mechanics of services work and spending time with the people who use and deliver services every day. I really love the unsexy parts of service design. I love fixing the basics, and there is plenty to do in healthcare on both of those parts of the equation. While I love spending time in healthcare settings, I do have I have no clinical expertise. I have no training as a doctor. I don't know the details of how all the systems work, both technical and otherwise. And some of the people working in these settings can be sceptical about what I do and why I'm there. Rochelle set us up very well for this talk in terms of the need to build trust across national and local parts of the NHS. So, enter Videha.
Thanks. So I am a doctor, which means most people think I spend most of my time in hospitals, walking around wards, wearing scrubs, saving lives. Really, I just stand around and pose for photos, which is probably why it takes so long to see a doctor when you go to the hospital. But anyway, I obviously love working for the NHS. I love looking after patients, and having been part of the NHS for over 15 years, I've seen a lot of change in my time. It's become increasingly difficult to practice in the NHS, and there's lots of challenges that keep just getting bigger as time goes on. And I started to reflect on the fact that if we truly want to transform healthcare, if we really want to make services work better for the people that use and deliver them, as Emma said, we really need a radically different way of problem solving. And for me, this is where design comes in. I knew very little about design, so I worked hard to try to upskill myself. I did a PhD in health informatics, specializing in digital innovation. I'm now building a tech startup focused on making healthcare more personalized. And as part of this transition, working with people like Emma has been super important for me. So now you can also find me moving post-it notes around walls and making hero boards and running workshops. And as I've made this transition from doctor to clearly wannabe designer, I realised how dramatically different those approaches to problem solving are. So when I think back about my training as a doctor, we're taught to think in a very specific way. As soon as a patient walks into the room, we're trained to immediately look for clues, things that we can pick up that allow us to go from a long list of possible things that could be wrong with someone down to a single diagnosis as quickly as possible. Do they have a rash? Do they walk in a particular way? What are they wearing? Who have they brought with them? It's kind of Sherlock Holmes type way of thinking. And that works really well if you are a healthcare professional trying to make a quick decision in a time-pressured environment. But if you're trying to solve complex, knotty problems, like how do you reduce waiting times? How do you improve patient experience? How do you introduce a new service into a complex environment? That way of thinking does not work. And there's probably two main differences when I reflect upon clinical thinking versus design thinking, if you like. Firstly, we are trained to really go with our assumptions. So we're trained in medical school, common things are common, which means that you try to go for what is most likely and you place your bets early. So you try to go with your assumptions, you go with your past experience, you use your muscle memory to make decisions as quickly as possible. Together with that, we're very good at asking questions that allow us to narrow down what could be going on. So we're very good at converging, not very good at diverging. The first time I saw the double diamond, my mind was blown. I was like, well, you can go out, all you can do is go in. So there's been a lot of change in my thinking as time has gone on. So yeah, as part of that journey, I've tried to step outside of my comfort zone. Typically, I would go to healthcare events. I would not necessarily go to a digital design event, but I started to do that a few years ago. And one of these type of events is where I was lucky enough to meet Emma. We've since then built a partnership together and had a chance to do some projects together. So it's very, it's really like a privilege to be here to come and talk to you about some of the work that we've been doing. So just before we tell you about our project, I thought I would just share with you a very quick example of the status quo, of how we maybe sometimes have introduced new technology or innovation in the NHS in the past before I hand over to Emma to take you through our project. So this is a real life example. This is how I was introduced to a new service within a hospital that I was working at, which was going to change how we refer patients to a neurology department in a neighbouring hospital. It's an organisational-wide forwarded email saying this new thing is happening, feel free to cope. The title of the email says patient passed neurology 1st of March 2021. The email was sent on the 8th of March 2021. So that already is a great start. There's nothing in the body of the email that tells you anything about what the service is, how it works, how to use it, how to access it. It just says, dear colleague, there's a letter from someone together with some posters for information and wider distribution. Most people that are, of course, working on the clinical front line haven't got time, barely got time to open their emails, let alone open some random attachments. Obviously, I did because I'm curious. And then when you open the attachment, it's just essentially an advertisement from the supplier of the digital product, as opposed to any information on how to use the tool. Of course, the flyer does have a QR code on it because we love QR codes in the public sector. When you scan it, it again just takes you to the homepage of the company that made the tool. So this is not how we wanted to introduce new innovation. This is not how we wanted to do our project. So we really wanted to take a much more design-led and co-developed approach. So I'll tell you a little bit of background on our project before I hand over to Emma to take you through what we exactly did. So now taking you to the real-life front line of the NHS, and most specifically into the pretty exciting and innovative space of genomics and personalised medicine. So, as you will all know, we all respond differently to medicines. Sometimes a medicine works well, sometimes it doesn't work well, sometimes people have side effects. But did you know that our genes play a big role in determining that response? We're all individually unique, we all have different characteristics, height, skin tone, etc. And how we process medicines is another one of these characteristics that is determined by our genetic code. If we are able to check for these different versions of genes that people could have, we'd be able to make medicines more personalised and allow people to have the treatment that's right for them as individuals. That's sometimes known as personalised medicine or precision medicine, which is a term that people might be familiar with. Now, the science around this is super mature. We understand the relationship between genes and medicines really well. but it's not part of everyday care. It's not like any of us goes to see the doctor and the doctor says, hey, actually for you, this medicine's not going to work, I'll give you this one. Or they might go and say, I'll give you a higher dose because your body processes medicine more quickly and it gets flushed out of your system. So even though the science is quite mature, implementation has not happened, and that's because it's really, really challenging. And in healthcare, a lot of implementation is driven by policy and guidelines. So specifically around this topic, we were very excited to see a specific guideline that came out nationally that recommended that all patients from now onwards that have a stroke should have a genetic test to guide what medication they should be given afterwards. A stroke is a brain condition caused by a blood vessel that's blocked that's going to the brain. So by doing a genetic test, we'll be able to select the best medicine for a person who's had a condition like this and therefore reduce the chance of that happening again. And this is really important because 1 in 3 people don't respond to the most commonly prescribed medication that's given to patients after stroke. As part of this project, I had this genetic test as part of the background work, and I carry the version of the gene for which that medicine does not work. So if I was to have a stroke or even a heart attack, I would be put on this medication clopidogrel, even though it would not be doing anything for me. And that feels like a real waste of time, money, resources. So this was something that we were really, really passionate about and really wanted to try to get right for the NHS. So we had this opportunity to design a service to implement this guideline, and recognizing all of our past less good efforts, we decided to bring in Emma as a service designer at the start of the project to help us co-design the project and then help us deliver it.
No pressure, right? I didn't do it on my own. So what did we do? We partnered with 4 hospitals across the UK based on getting a cross-section of different geographies but also different sizes of stroke wards. And we started by spending time with them. We wanted to understand how their stroke wards functioned. At this point, as a service designer, I'm really trying to understand where and how I can add value. So this project really taught me a lot about how to integrate design at a local level. I'm not going to shout out Rochelle every time I reference her talk, but it's going to happen a lot throughout the next 20 minutes. Something that isn't common at the moment is design at that level. And I was really interested to kind of have this opportunity and to be in that space. So I took it slowly. I knew that this was going to be their service. They knew their wards inside out. They worked there day in, day out. They knew how to navigate the system to get things done. And there was really going to be no value in me lording it around with service blueprints and post-it notes. So the first thing I realised I could help them with was figuring out how their new service would fit into their current ways of working. So language is important here. The healthcare system works in processes and pathways, not journeys and blueprints, but actually it's all the same stuff. So one of my favourite moments from this project was process mapping in a consultant's office with about 9 people squashed into a 2-person room. In healthcare, you really have to take what you can get. So we also supported them to design key touch points of the service, touch points that they wouldn't normally get to have input into, like lab testing forms, for example. So this service crossed some of those many bits of the NHS that have been referenced already today, and it involved a lab that was separate to the hospital, totally different systems, totally different infrastructure, of course. So they would normally just get given a way to do this, but we had an opportunity to get input. I wouldn't call it co-design as such, but it was a step forward from what it would have been before, you know. So we were able to be that conduit. What was difficult was breaking through the hierarchy barrier. So we were people, you know, walking in from NHS England. There's that power dynamic at play already, asking resident doctors what they thought of a form. The usual response in this situation is, yeah, it's great. Because we're the power in the room, right? So we had to work to break that down. We had to first get the resident doctors away from their consultants because, again, they're not going to say anything in front of them. And then we had to create an environment where they felt comfortable and able to be honest with us. We also provided the space for staff from the different hospitals to share and learn with each other. Again, an opportunity they're not normally given. They're too busy, you know, delivering services and saving lives and maybe posing for some photographs. They were all implementing the same service, but they were taking a slightly different approach based on local context, based on their local systems differing, and we gave them the chance to borrow ideas from each other, basically. We set up some Teams calls, invited them along and just sat there and watched them talk to each other, basically. But that was valuable. And for me, it was all about figuring out what could be valuable, where could I add value as a designer at this local level. While we were doing all this work, we were gathering these learnings and building an implementation guide that we were then able to share with other hospitals that would roll out the service in future. Hopefully better than an all-staff email saying, feel free to cope. There weren't any QR codes in our implementation guide. So all of this was great, but my favourite thing about this project was our attempts to help the stroke ward staff implement a minimum viable service. This was, in my opinion, where I could add the most value. So it's very common in the NHS to do pilots. This was a pilot. You know, they have a start and end date, and they were very much operating under that assumption that they were going to do this thing for 3 months and then we'd decide whether it worked or not. We were really trying to shift mindsets and get them to think, okay, you're building a new service here. What's the minimum viable version of that service that you can build to get it off the ground, to get it running? We'll test, we'll learn as we go along. But that's new for them. They were nodding a lot though, so we really fully thought that they were getting this. And towards the end of the project, we got very excited because we managed to make the case with the funders to get them to continue funding tests in these 4 hospitals. They'd agreed to fund the tests for 3 months, and we were like, guys, we've built a service here. Like, if you stop funding the tests, they're going to have to rip out that service that they've already put in place. So can you keep funding the tests just in these 4 hospitals? And they were like, oh, yeah, sure. So we were really excited, found our consultant friend in the London hospital we were working in, broke the exciting news, and he said this. He said, you want us to carry on testing? Shit. We better get on to IT then and design a real service, hadn't we? Which, that was a real light bulb moment for me, where I thought, oh my God, I thought I'd managed this, and I really hadn't. So the reason we wanted to team up for this talk was to get the message across about how important we feel the combination of clinical and design expertise is, and if understood and combined effectively, what impact this combination could have on the system and what shifts we could make. In this story that we've just told, the case study of the project that we've talked you through today, Videha was able to navigate the hierarchy. He was the clinical in this combination. I was the design. He was able to talk the language. He understood the system that we were working within way better than I ever could. He brought the authority. He brought the context, and people could relate to him in a way that they couldn't to me.
Cool, and I think from Emma's perspective, trying to think back about the big impact that bringing someone with her expertise to a project like this was really bringing an external perspective into the group, because as I've already highlighted earlier, lots of our ways of thinking are often quite biased, and we often have our assumptions, and when we are too in it, too close to the ground, it's hard to see the bigger picture and connect the dots, which was what we saw was happening with lots of these clinical teams. We allowed them, we helped them to take that bigger picture approach. And one of the things that when I think back about some of those situations when we were all crammed up in the consultant's room or on this Teams call where you think what we did was put them in a room together, actually someone like Emma asking those open questions, those kind of unassuming questions that historically we would maybe be too afraid to ask. You might think, oh, I can't ask a consultant this question. Having someone who can see past those hierarchies and can ask open questions in a far more effective way and start to spark conversation that normally would just be not brought up was really, really important. So I think that combination of having some of that inside experience and expertise but bringing in an outside perspective really helped and worked in this example. But there are probably some other reasons that we believe combining these skill sets are really, really important. So we'll take you through 4 main reflections that we had as part of this project and why we think this combination really helped.
So the first one talks to that story I just told. We really believe that if we combine design and clinical, we can move from pilots with start and end dates to designing services iteratively. As I already said, pilots are really common in the NHS. They get done a lot. They tend to be for a fixed period of time with a start and end date, and success is measured in a pass-fail spectrum, go, no-go. It's all very binary, you know. But that's not what we need to be doing. We need to be designing services iteratively, testing and learning and improving as we go. In the example that I told, it's talking back to that kind of light bulb moment when they were like, oh my god, I need to go off and design a real service now. What they were actually designing was something that would get the tick in the box, that would get them that pass mark, that would make it look like they designed something great, you know. But they were not designing something that was sustainable or scalable. They had consultants taking the blood samples because they didn't want to risk phlebotomy being involved in their exciting pilot because it might go wrong. But who normally takes the blood samples? Not the consultants. So that wasn't an example of a minimum viable service. It was an example of getting through their shiny pilot. So how do we do this? Does a shift in language help? I don't know. I had an argument with myself on LinkedIn about this recently. But ultimately, I don't really care what we call it. Discovery, alpha, beta, is it design? Is it, well, now it's test and learn and grow, apparently. Like, if this language helps sell in the approach, sure, go for it. Call it whatever you want. But the outcome is the same. It's an iterative way of operating. The culture of implementing something minimum viable is not there in healthcare currently, largely because of the risk-averse nature. We need to get better at helping the system understand that a minimum viable service doesn't mean an unsafe service. This is where I believe, or we believe, that a strong partnership between design and clinical can really help, and especially involving clinical expertise from the start, not just for clinical assurance at the end.
Yeah, just to kind of add to what you've just said there, one of the things that I've seen a lot of my colleagues talk about, or the way their mindset is that until the project's finished, they think that until the project's finished, we haven't learned anything. It's like the day before the project's finished, we've learned zero, and then the day after, we've suddenly learned everything. This concept that we're like continually learning, until we've written the paper and published it, it's not real. It's like, you've got lots of findings already that you can start to act upon, and this kind of way of thinking is just really something that, you know, I'd love for people that think like this naturally to come and like share more in healthcare. So the other big challenge, which I think is true in healthcare, maybe also in other traditional industries, is around hierarchy. So we really think there needs to be a shift from these top-down hierarchies to everyone involved in delivering a service having an equal voice. So in healthcare, we have this ingrained culture of hierarchy, and you know, it may have historically worked when perhaps the problem is clear or there's a need to make decisions quickly, but when you are in a complex, sprawling environment like the NHS, it really doesn't work. It doesn't work well when problems are complex and when the answers to those problems are distributed amongst many different people. The answers are not in the head of the consultant or the professor or the head of the department, which is who we are typically sent to first when we are introduced to a project. So, you know, it shouldn't be that that is the only voice that matters. And I think part of it is not just, it's not the fault of, I think, individual professors, consultants, or people in senior leadership positions. I think more broadly, the organizational structures have poorly defined roles and responsibilities. So someone might be a clinical lead for a service, but that's a role that they do for 2 years, 3 years. That is almost just part of their journey. It's not like they've had specific training and they've then become the clinical lead. It's like a baton that's passed from person to person. And that does not reflect their expertise or maybe even their interest in terms of driving transformational change or what area they want to drive transformational change in. So one of the things that we often talk about is you try to look at other industries and how they innovate better, and bringing people from design backgrounds into these spaces. I certainly have firsthand seen how it helped flatten those hierarchies out. Having someone in the room who is not part of the traditional hierarchy, who can cut across historical boundaries, is something that's really, really important. I'd love to see more of that.
So the third shift we'd love to see is to move beyond consultative engagement activity with patients or people, stroke humans, to embedded co-design approaches. We didn't get to do co-design for this project. I would have loved to. It is something I'm really passionate about and I want to do more of, especially in healthcare through my practice with Design for Joy. Patient and public involvement and engagement, or PPIE, as the healthcare system loves an acronym, is common, but it can be tokenistic at times, or even, and I've forgotten your lovely term now, Rochelle, but something to do with vampires, which I thought was brilliant, because it can be extractive, you know, and that is not what we want. I've got no doubt that there are pockets of this happening around the system already. You know, we've seen some great examples today already of co-design and co-production work going on in the system, but we need more. And I want to highlight here that I don't think that designers are a magic bullet here. This is not about doing it our way. What we need to do is find these pockets of great work that's happening where you're designing with people and amplify that, you know, replicate it, do more of it. In healthcare, I think the real challenge is co-designing within constraints. And when you have that at play, which you're always going to have at play in healthcare, whether they are clinical constraints, safety constraints, all of the sorts of constraints that go on in the healthcare system, we need to set really clear expectations up front. And I think that's where the combination of clinicians and designers comes in again. You know, I'm going to be doing some work next year, hopefully, with the University of Sheffield to support some work to co-design patient-friendly radiology reports. And I'll be working alongside a practicing radiographer for this, because there are so many constraints with this, right? You can't just rip up how we do radiology reports and do them differently because this group of humans that we're co-designing with want it this way. So we're going to have to work really hard to clarify from the outset what those constraints are, what's up for grabs, what isn't up for grabs. And I can't do that without a clinician in the room.
Cool. So the last topic that we wanted to cover relates back to that point around different ways of thinking. So in healthcare, we still really have this convergent kind of diagnostic style of thinking, and we need to really move more towards this divergent, open-minded way of thinking. And I've managed to pivot perhaps my approach to problem solving, you know, thanks to partnerships and being parts of different communities. But how do we shift the mindset of others? And that's not really easy at all. One of the things that I try to do, certainly with my kind of more healthcare colleagues, is demonstrate the value of slowing down and staying in that discovery phase longer, giving examples of times or examples of when we have made rash decisions and it's led to poor utilization of resources, poor outcomes for patients, not creating the impact that we can. We also often give examples from other industries. So, you know, why are our phones so addictive? As well, the people that design these things, they desperately obsess over their users, and they spend, you know, loads of time trying to understand how people behave and what they do. Do we do that in healthcare? Not at all. We don't spend time with our users, be it clinicians or patients, nowhere near as much as we should do. We're thinking specifically about health IT and about my PhD, and I read a research paper which reviewed 11 of the largest electronic medical record companies in the US. So these are very large, you know, multi-billion dollar corporations, and it looked at how many UX staff they had on their payroll, and they found that out of these 11 companies, and these are tech companies, and of 11 companies, only 4 of them had what you would describe as well-developed UX processes, and 4 of them didn't have any UX staff on their payroll at all. These are companies building software that's used by tens and hundreds of thousands of people around the world to deliver care every day, and they haven't got usability staff as part of their team. So it's no surprise that doctors hate their computers, right? Like, it is no surprise that these things do not work for them. In fact, there's actually a really good article by someone called Atul Gawande, who's someone who I've looked up to for a long time. He's an American surgeon and best-selling author, and he wrote for The New Yorker about his experience of being trained up to use a new health IT system in the hospital in New York, and his experience around that are really, really interesting to read, so I very much recommend checking that out. In fact, it is called Why Doctors Hate Their Computers, so that's an easy one to find.
So we've talked about 4 key shifts today. If you're interested in reading more about this, I'd really recommend this piece written by James Plunkett a while ago. He does a good long read if anyone enjoys bedtime reading about nerdy design things, which I do. And I was pleased to say, actually, when I read this in the development of our talk, he was highlighting a lot of the things we were highlighting. He goes into a lot more detail, so that's your homework. So how can you all help with this, I hear you cry? We have influenced the culture in a small way. We're really proud of that. We love hanging out and working together and doing the things that we do. But imagine if we could scale that up. I get really excited when I find someone who is currently working in a clinical role who wants to move into design, because that combination of skills is not seen very often in the same person. Videha has it, which is why I feel so privileged to work with him. Sadly, we can't clone him. So we do need to think about how we can get design and clinical closer together. So if you're a designer who has never worked in healthcare, maybe think about giving it a go. There's 4 big tech companies in the US that could give you a job maybe. If you work for an agency doing projects in the NHS, have you got clinical folk involved from the start and throughout? Agency owners or managers? Is all your healthcare work with NHS England, soon to be RIP, DHSC? Oh God, that's a lot of letters all in one go. What about approaching trusts or ICBs? Can we think about how we can get more design more at that local level? They can't afford it, by the way, so you might have to do it for free. Tech startups, have you got design and clinical folk involved with designing your systems? If you haven't, that's criminal. If there are any clinical professionals in the audience, firstly, bravo for coming to a design and digital conference, and secondly, come and speak to us afterwards, because we'd love to meet you. Thank you. I think we've maybe got a couple of minutes for questions, if anyone has one, but thank you so much for having us.
Okay, I have a lot of questions.
Oh, maybe pick your
I
favourite.
just picked one. So, Vidya mentioned the double diamond. Okay, so my question is, why double diamond? Why not design thinking, steppers or centers, maybe something else? Why do you guys that specific framework? Yeah.
I don't think we do. I think Videha, he can maybe build on this, but I think he was referencing that particular framework to highlight the kind of difference between convergent and divergent thinking. And I found that really interesting when he first told me that story, and how doctors think, like their brains are just trained to like narrow down, whereas I think designers' brains are trained to like narrow out, and that difference I think was really interesting, and actually partly probably why we work really well together. But we certainly don't have favourite frameworks. I'm just a designer who does stuff.
Just building on that. So, is there a specific framework that you guys would, recommend for designers, or something that you have used?
No, sorry. I trained at an agency called Snook that are not alive anymore, but well, the people are, but the company isn't. Just to clarify. And we were very loosey-goosey with the way we worked. Like, we just kind of made up frameworks as we went along to kind of get to the actual desired outcome that you want. So I'm not a big fan of frameworks. Sorry, I feel like I'm really not answering your question. But I feel like you should start with like what you want to achieve, what problem you want to solve, and just work backwards from that. There's plenty of frameworks to go around. Like, just find the ones that you like. There's no right or wrong. Cheer for that. Thank you.
Oh, thank you.
Brilliant.
I am. Oh, you vowed to be now. Excellent talk. Thank you very much. I was really interested. You had a photograph of kind of the hospital ward, and obviously from kind of some of the research that you're doing. Having attempted that myself, like, how do you overcome the kind of the challenge of observing people in a really kind of critical and like time-sensitive and important kind of environment where you're trying to understand what's going on. You don't have the clinical frames of reference to really be able to follow it, but you can't interrupt them and ask a question.
Yeah, I feel like I'm just not going to be able to answer any questions. We didn't really do it, is the short answer. We were working predominantly with staff for this service. We did have a really awkward interaction with a patient in the room, didn't we? Should we tell that story? Yeah, we didn't get to really interface with patients for this work. They're kind of part of this service. Yes, they had to have the test done, but what we heard from staff is like they're going to just do what we tell them to do. Like, if their kind of viewpoint was like, they're not really going to have a view on this because they're here, they've had a stroke. Like, largely people were in very vulnerable situations, and it was a case if we're recommending this test, they'll probably just do it, you know. It has brought to mind actually, because I'm working on a current project where I am going to be going out into the community and observing like health checks, so it's much lower level clinical intervention wise than like strokes and tests and stuff like that. But I'll keep that in mind and give you a call in a month and see what I did in that situation.
The only thing I would add is, because Emma also, highlighted some of these things around, we're in these clinical settings, like, are we not disturbing the workflows, etc. I think for me, because it's like a natural environment for me, I was like, I was going to talk to this patient, it's fine, it's not a big deal. Or like, oh yeah, we just ask this person something, it's fine, it's not an issue. Yeah, matron, can we ask you this? Blah, blah. So just because I'm like obviously so familiar in that space, it felt, I've started to feel conscious about it, like, oh, should I be talking to this person? Am I disturbing them? I never really thought about it before, but maybe I am.
But that's an interesting difference between us, right? Like,
Yeah.
I would be like you, I'd be like, ooh, whereas he's just like, yeah! Another good reason why design and clinical come together. One more.
I wondered if you could talk a bit more about the idea of iteration and selling that to the NHS, because that feels like one of the biggest barriers we have is that when we're designing something, particularly designing a service, it's probably not going to be right first time, and how do we reassure people that that's kind of okay, but to demonstrate that if we keep doing the work and if we are given the space and time and money to iterate, that might work.
So I think maybe one of the ways, and this I'm thinking on the fly, is a great question. I wonder whether maybe one of the things that we could do differently is what we have when we set up projects, like we've been talking about, you have to kind of start date and end date, and we had that. It was actually maybe what we could have done differently, and this is very much on the fly here, is maybe we could have had like a date a third the way through the project to say this is where the MVP goes live. This is where V2 goes live, and this is where V3 goes live, and kind of like bake that iteration within the project plan so people start to get early into the mindset. It's like, we don't have the finished service at the end, we need to have the finished service like now, in like a month's time, which means that we need to make, decisions that are safe but maybe more minimally viable, which we maybe wouldn't have done historically. Maybe that's like a very practical way to do it.
I do think it also comes down to the risk, the currency of risk. Like that's the biggest thing I remember from when I worked at NHS Digital as a full-time employee, just how strong that currency was, And I talked previously about it not just being a minimum viable service, it has to be a safe service. So I think that's the big assurances they need. So thinking about how you can build that assurance in to make sure that, yes, it might be minimum viable, but it's safe, it's not going to do any harm, it's, you're minimising your risk, but you're still getting something out there. I think that's the big barrier to get over for me.
Well, we're out of time, I'm afraid, but thank you very much, Emma and Videha. Well, thank them.